Hi, my name is Dr. David Reina. I'm a chiropractor for Florida Orthopaedic Institute, and today I'd like to talk to you about the foot and the knee and how they work together or how they work separately. So, a couple things that are interesting about a joint. There's three different type of mechanisms that help to hold a joint together. If you look at this very famous researcher called White and Punjabi, they talk about different subsets. So you've got a passive subset, which are the ligaments and the intrinsic tone of the tendons that cross the knee joint. Then you have the muscular type of subset, which are the muscles and the tone of the muscles across the joint. Then you have the dynamic or the neural subset, and this is basically the information that occurs from what's called mechanoreceptors, or these little nerve endings that cross the joint or within the joint or within the muscles that give feedback to the nervous system in order to have controlled movement. So those three things are important in order to have coordinated movement and joint stability. So let's bring this into play. Here's the knee joint, and Allie had an ACL surgery a few years back. The ACL is a ligament within the knee joint that stops movement forward and backwards. You have a PCL and an ACL. So what we're going to look at as far as the knee is concerned is the stability of the knee. One of the things that people often don't look at when you're looking at stability of the knee is the position of the foot. So for example, when you're looking at the leg and the knee functionally, if the foot has a tendency to fall in this way, called pronation, then what it does is you're going to have increased stress on the ligaments on the inside part of the knee, and contraction of the musculature on this side of the knee here. If you'll take a look at Allie's knee, notice how this one here is straight. If you look at the leg, and notice you see the angle of the knee, this is called a valgus, or a V, all right? This lets me know that she's had a chronic pronation of the foot. So, when there's chronic pronation of the foot, there's a group of nerves that come through here, the tibial nerve, and then you have another nerve on this side here called the common peroneal. The tibial nerve serves the bottom of the foot. This nerve here on the outside serves the top of the foot. So you can imagine over a time period, if you have pronation of the foot, you compress the nerve and the blood vessel here, numbing the foot out. You compress the blood vessel and the nerve across the back, that numbs the top of the foot out, and now you have a sleepy foot. So if you ever laid on your foot or gone to the movies and had your legs crossed for a long time and then tried to get up, what ends up happening is you can't get up, because as your foot numbs out, your brain doesn't have feedback to the floor, and then the muscles that hold you up go weak. So imagine if you just turned off the foot about 10 or 15% for 5 or 10 years. You'd be working with a weaker knee because you had less influence. So when we look at the leg and we look at the knee and the function of the leg from a clinical and from a functional standpoint, we understand that. What we want to do is we want to improve the sensation under the foot. Why? Because the greater the sensation to the foot, the greater the strength you're going to have with the legs, which is going to increase the tone, which is going to increase the strength of the knee. So here's how we do it. We're going to take the toe. I have my finger here on the pulse, all right? Her pulse is a little bit reduced in its intensity. Once I take the toe and I move it over, I can feel her pulse increase. The reason it increases is because once I put the toe to this position and I put normal stress across the foot, it takes the pressure off the ankle. This way I know that her foot's and her ankle's in a normal position. Once this is occurring, I just hold it in this position, basically perfusing the leg or increasing circulation to the foot. And then I check it out. See how sensitive? It becomes extremely sensitive. And then I want you to notice as I bring my foot up, notice the muscles in her leg. The muscles in her leg start to contract. Like a big computer, she gets feedback, and then the brain organizes. Regarding the knee, excuse me, now what we'll do is this. The knee wants to go into a valgus or a V. What I'll do here is simply put my finger on the back of the knee. There's a pulse on the back of the knee called the popliteal pulse. And we just put an easy pressure from the inside out, or from medial to lateral. In this position here, I can now feel the pulse open up. So I rotate the knee until I can feel the pulse open even greater, and now it's open. Now I know that there's probably reduced pressure on the common peroneal nerve, which is the nerve that feeds the outside part of the leg. I just hold this position, and then I ask the patient to straighten your leg out, and then I have her bend it and then straighten it out. I have her do it because now what I'm doing is I'm holding the knee in a normal position as she actually contracts the muscles. The attachment side of the muscles and the force actually realign the leg. Good. And relax it. So if you notice, just doing that, notice the symmetry of the legs now, just with the contraction. So reduce the angle of force. Again, when we're looking at rehabilitation of the lower extremity, especially the knee and the foot, you have to look at them simultaneously, because again, like I said before, changing position of the foot or function of the foot is going to change function and position of the whole lower extremity. So whenever we have patients that are coming in like this, we want to make sure that we're looking at the entirety of the leg, not just the local effect of the knee or of the foot. David Reina at Orthopaedic Institute. Have a safe day, Tampa.